I thank Bayer for giving this opportunity to me to present this data on ARASENS and darolutamide ASCO GU updates on 2025 updates. So these are the slides given to me by Bayer. So this is an important slide when we look at the spectrum of trials which have changed the treatment in metastatic hormone-sensitive prostate cancer setting, starting from CHARTED trial, when we started learning in 2014 that docetaxel does help in sensitive cancer, to a PEACE 1 trial, which was in 2021 that you can use abiraterone along with chemotherapy, along with docetaxel, to ARASENS when darolutamide plus ADT plus docetaxel has shown promise, and ARANOTE. So we've had ENZAMET trial in between where enzalutamide was used plus minus docetaxel. Again, the trial had some limitations, led to higher incidence of seizures and toxicity issues. So let's look at deep dive into what these trials have taught us. This is an important slide for all the students, who would be taking part in the quiz. This is somewhere you can see all the trials being clubbed into one slide. And you can see that majority of them had good hazard ratios, but the control arm is pretty different, is pretty weak in majority of the trials in the AR pathway inhibitors, whereas in the triplet regimen, the control arms have been strong and the hazard ratios have been slightly dropping. How does darolutamide work? Darolutamide is androgen receptor inhibitor, but the good part where it scores over the ENZAMET trial is that the CNS penetration is only 8%, whereas the enzalutamide has a CNS penetration of about 81%. So potentially the toxicity of the ENZAMET trial, which led to higher seizure activity in elderly individuals, is negated in the darolutamide study group because of the lower CNS penetration. Apart from this, darolutamide itself as a drug causes lesser drug interactions, and majority of these patients being elderly, and it's a big challenge for them to give multiple drugs. So this drug in the triplet regimen really helps because these patients are on antihypertensive, anti-diabetic medications, antidepressants, mood elevators. So it's a big challenge in this subpopulation to add a pill burden. And darolutamide is much better than enzalutamide and apalutamide in this regards. So this was a simple 1:1 randomized trial, and which looked at basically two subgroups, darolutamide versus placebo. Both the subgroups received docetaxel. Very well randomized trial. Primary endpoint overall survival met the hazard ratio of 0.68. You can clearly see the curves far apart, started separating at 3 months interval and continued to do so. So there was an overall survival median was not met in the darolutamide arm versus 48 months of ORS in the placebo ADT docetaxel arm. And the primary endpoint was met, the risk of death reduction by 32%, which was also significant. You can see that this benefit was consistent with de novo and recurrent disease. Even patients who had an M0 and initial diagnosis, they also benefited with the same approach. Now this is important. The trial also suggested what we would classify as a high volume as based on the CHARTED criteria, and a high risk disease on the latitude criteria. So this was a subgroup analysis on high volume disease where the patient were subgrouped into visceral metastasis or more than 4 bony mets. It met the endpoint. You can clearly see the curves far apart. And high risk group where the Gleason more than 8 or more than 3 bony lesions or visceral metastasis, 2 out of the 3 criteria, again met the the endpoint. Low volume disease where we still are little skeptical on the use of triplet regimen is something where you can see the curves really meeting together. This also led to an improvement in time to castrate-resistant disease, something which we are worried in prostate cancer, and you can clearly see that the triplet regimen did improve time to castrate resistance. Time to pain progression, time to initiation of subsequent therapy. These are all important aspects when we look at the secondary endpoint in treating a prostate cancer patient in elderly. So pain progression is one of them, And this triplet regimen led to a significant improvement in this subgroup as well. Again, you can see the robust PSA response in the darolutamide arm across all the timelines at 12 weeks, 24 weeks, and across all the timelines. In terms of side effects, adverse events were pretty well matched as compared to the previous studies where you had abiraterone or enzalutamide. Abiraterone had led to higher incidence of hypertension, and enzalutamide had led to higher incidence of seizure, but this was not seen in the darolutamide arm study, and you can see the side effects are pretty much similar. There's no added red flag on which was the added side effects. So when we look at the most common comorbidities in patients with prostate cancer, hypertension, diabetes, cardiovascular, osteoarthritis, cholesterol, sexual dysfunction, depression, and urologic complications, this is what men above 75 generally tend to suffer from. And you can see darolutamide, when it comes to the drug safety profile, does not interact with depression or cardiovascular medicines. It has some interaction with rosuvastatin, but apart from that, which is a drug which we can actually easily, modify or give up, but well tolerated in terms of other drugs, it does not cause much interaction. Whereas if you can see enzalutamide, you will have to reconsider the dosage of rivaroxaban or verapamil, and same is with abiraterone. You have to monitor the toxicity from atorvastatin, rosuvastatin. So quality of life, yes, maintained. Patients want to live longer, yes, maintained. And overall survival increased 63% versus 50% in the darolutamide arm. So this drug really met the endpoint as far as the patient preference was concerned. So in terms of management of hormone-sensitive prostate cancer, the several questions were met, but there's something which we don't know, whether M1 disease is generally not recommended. ADT alone in M1 disease, do we give it for a fit patient? Volume is again something we don't know, and both high and low volume disease have similar benefits, but what low volume disease will not have benefit from triplet regimen, very difficult to say. So darolutamide is a new standard as far as this trial is concerned. It requires minimal patient monitoring. It is a potent androgen receptor inhibitor with a robust activity, and it is a low risk for drug interactions, and that is something the company is really proud of and promoting in this subgroup. So I'll just present you the data on the ASCO GU 2025 143 abstract, which looked at age as one of the subgroup analysis. So this trial was dissected based upon the age less than 75 and more than 75 years of age, and then in terms of all patients versus patients in the trial itself, it was well randomized in this two subgroup analysis. Patients had different comorbidities, well balanced in these two subgroup analysis. In terms of data, you can see efficacy of darolutamide versus placebo. Even this subgroup analysis was well maintained. The triplet regimen with darolutamide benefited patients equally in patients below 75 or above 75 years of age, with the curves far apart. So, one, this was safe. Two, this continued to show benefit in this subgroup, which really may benefit from this. So, efficacy in terms of time to metastatic castrate-resistant disease or initiation of subsequent therapy, subsequently prolonged with the introduction of darolutamide, according to the ARASENS trial. So age-related efficacy, again, no greater toxicity was observed, and patients who had received subsequent therapy were able to tolerate. Abiraterone was the most common subsequent second-line therapy in this subgroup. Safety, again, well managed. So in conclusion, patients with metastatic hormone-sensitive prostate cancer benefited irrespective of the age in terms of OS or PFS. It was well tolerated, and this result also supports the use of this drug regardless of the age something we need to consider as physicians when giving this drug to Indian patients. Sometimes we tend to undermine age as one of the factors in determining our kind of therapy we want to give to them. Now let's look at whether GCSF had any impact on this subgroup. So in this population, another data was presented where relative drug index, concentration index was subgrouped as one of the important factors, and this was determined. So you can see that GCSF, even in pre-planned, 47% were pre-planned for concomitant use, and without concomitant use up to 52%. But there was no difference in the outcomes of overall survival when the patients received darolutamide. So there were no added patients who had dropout because of the GCSF use or the drug toxicity, docetaxel toxicity. Both the subgroups had similar outcomes. So the treatment-related adverse events leading to docetaxel dose modifications were higher, with docetaxel relative dose intensity of less than 85 versus more than 85%. Incidence of febrile neutropenia were pretty much same. Almost all incidents were same. So this drug was safe, and growth factor usage is something safe in this subgroup. So with this, I would like to end my talk and